recording now, and we will share this once the presentation is over.
Can you see the slides now?
Yes, thank you, Trang. So welcome everyone to part 3 of the Learning Disability and STOMP Awareness webinar series. So today we will be focusing on MDT support and how different healthcare professionals can help towards improving the outcomes of our LD population. So if we go to the next slide, please, Trang. We'll go through the agenda. So today's agenda will include introducing the function of three key stakeholders. So we will have Dr. Jenny Shaw, a clinical psychologist, talking to us about mental health in LD and clinical psychology, followed by Liz McGrath and her team, who will talk to us through the function of the community LD team and complex physical health nurses. And then we'll be finishing off with Elizabeth Deeves, who is an integrated commissioner for the Bexley Borough. And she will talk to us about the local authority, how they fit in, the commissioning side of things, and care and treatment reviews. So if we go to the next slide, I believe we have a Menti question. So Trang will do her magic and switch her screens. If everyone wants to just scan the barcode, it would take you directly to the question.
Okay, before I'll start, I'll leave the barcode on for a little bit before we see the actual question, and we can start seeing the results then. I'll give 30 seconds for everyone to scan or input in the code. Right, so hopefully everyone has scanned. So today we just wanted to get a gist of who have access to certain teams and who have, thought about who they can access. So the question is, in the past, which teams have you liaised with for a non-medical issue? We have a variety of answers. There's the clinical psychology team, there's the psychiatry team, the learning disability nursing team, social care team, speech and language therapy team, occupational therapy, physiotherapy. We also have LD or mental health nurse and social prescribers as well. So lots of people anticipating and participating, which is really great. We'll leave it up a little bit further just so that everyone can put their answers through. Really encouraging that we've seen lots of people accessing lots of teams. The numbers are still rising, so I'll leave it up just a tad more. So we have social care in the forefront, following behind with social prescribers. Okay, so I think the voting has stopped there. So what I'll do is I'll switch back to the presentation.
Thank you, Trang. So without further ado, I will pass it over to Jenny, who will take us through the role of the LD psychologist in Stomp and Stamp and behaviours that challenge. So over to you, Jenny.
Thanks, Ashika. Hi, everyone. I'm Jenny. I'm a clinical psychologist and I work in the Southwark Enhanced Intervention Service and MHLD team. I also work for the ICB as a clinical care professional lead in the LDA programme. So that's what I'm going to be talking to you about today, is the kind of role of the psychologist in Stomp and Stamp. And we're going to be focusing mainly on behaviours that challenge. Can we move on to the next slide, please, Trang? Okay, so you can just click through these. So this is the definition that we use for when talking about behaviour that challenges. So we're looking at culturally abnormal behaviour, which is intense and frequent, and is kind of sufficient in duration, that it causes a problem in terms of safety, putting someone in kind of jeopardy or causing harm, or kind of reducing someone's access to kind of day-to-day life, basically. So that's the kind of definition that we commonly use when we're thinking about what is behaviour that challenges. So we're thinking of things like people hurting themselves, hurting others, being verbally aggressive. I think there's two more, Trang. So inappropriate and danger-seeking behaviours, and basically that's serious enough that it's impacting on that individual's day-to-day life or on the day-to-day life of someone who is looking after them. So it may be that the individual in question isn't that concerned, but their carers are really struggling. So that we would say is behaviour that is challenging to somebody else. Next slide, please. So we're talking about behaviour that's unique to an individual. The term challenging behaviour or behaviour that challenges isn't intended to be a diagnosis or a label in itself. And I think the key thing that I'm hoping you'll take away from today is that behaviour always has a function. Next slide, please. So in terms of challenging behaviour, we think of it as communication. So individuals with learning disabilities and autism often engage in challenging behaviour as a way of telling us that something isn't right. So that's always our first question, is finding out what's not right. So it may be that there's a mismatch between their physical and social environment and their needs. So maybe the kind of carers they have, or literally their physical environment, or it may be they have unmet health needs. It can be helpful to think of behaviour as a form of communication. So if someone doesn't have the words to tell you what's wrong, maybe they're using their behaviour to tell you. And I think this is quite a key thing. We all have potential to engage in challenging behaviour at these times. So if you think about maybe a time where you've not been able to find the right words to express how you're feeling, you might have kind of thrown something or shouted or kind of done something that somebody else might have found challenging. So we all have the potential to engage in behaviour that challenges. Next, please. So we've already said this. So all behaviour has a very specific function. So the role of a clinical psychologist, so this is essentially what we would try and do, is we do a lot of assessment to kind of gather information about somebody's kind of life and themselves, and about the behaviour. We offer an approach called positive behaviour support, which most of you might have heard of, or PBS. We use systemic work, so that's working with families and networks. We do offer psychological therapy if we feel that that's something that the person may benefit from and wants to engage in. We also offer case coordination when somebody's having kind of support for one of the kind of things above. So that would involve things like network meetings, liaising with social workers, liaising with the rest of the MDT, basically, to try and get things right for the person. And we offer kind of case formulation or consultation. So even if a case isn't necessarily open to us for a full episode of kind of assessment and treatment, we might be able to become involved just through case discussion or consultation. So we might be able to give kind of an opinion on something, even if they're not kind of formally assessed by us. Next slide, please. So why positive behaviour support? So behaviour support should be the first line intervention for people with learning disabilities whose behaviour challenges. So that's according to the NICE guidance for people with learning disabilities who engage in challenging behaviour. So the NICE guidance says that antipsychotic medication should only be considered if psychological or other interventions alone don't produce change in the time that has been agreed upon. For treatment of any coexisting mental health problem that has not led to a reduction in the behaviour, or next one, please. The risk to the person or others is very severe. And then there's one final point. The kind of NICE guidance says only offer antipsychotic medication in combination with psychological or other interventions. So basically, the first line intervention should be a kind of behavioural support. We do sometimes have medication prescribed before or in kind of as well as behaviour support if the risks are very high, but we try and get in with behaviour support quite quickly where we can, particularly where we've got an intensive support team. Next slide, please. So the main aim of PBS is to improve the overall quality of life of the individual. So that's the focus of PBS. The reduction in behaviour should go hand in hand with this. So when we're doing PBS, we're not actually looking at reducing the behaviour, we're actually looking at improving someone's quality of life. And if we do that, the behaviour will reduce. What constitutes a good quality of life is different for everyone, and everyone will have different things that are important to them. So getting to know the person is really important, and the family or the system around them. So the way we do this in PBS is to develop an understanding of why the behaviours of concern are happening. So that's finding the function, helping to establish new behaviours or skills in the person or their carers. So that might be teaching the person kind of how to request something they want rather than relying on behaviours. Or it might be teaching carers different ways of interacting with the person to make sure that they kind of get their needs met. Or it might be making changes to the kind of the physical environment or kind of the social environment for them. So maybe we decide they're living in the wrong place and they need to kind of live somewhere that's quieter, for example. Slide, please, try. So these are the elements of PBS. So this is what we'd be doing. So during the assessment phase, it's really important that we gather lots of information. So you might have been involved in PBS assessments. They can be quite lengthy at times, particularly if someone's quite complex. So we're looking at triggers, we're looking at ABCs, which means antecedent behaviour and consequences. So basically that means what's the behaviour, what happens before, what happens after. We're doing observations, and that might be across multiple settings. We're looking at people's records and reviewing kind of historic records. We're interviewing people who know the person well. We're doing outcome measures, and we'll always investigate physical health to make sure we can rule that out for any cause. And then after our assessment, we move on to the formulation, the intervention, and the evaluation. So if we go on to the next slide, that just tells us a bit more about the formulation. So a formulation is basically a kind of way of understanding a problem. So psychologists often talk about formulation because we like to do formulations. So they're basically a kind of a map or an explanation of why something's happening for that person. So in terms of PBS formulations, we're looking at, we're making sense of the person's behaviour in their context. So why it's happening for that person in their life at that time. So it goes beyond just ABC, so antecedent behaviour consequence, and it's looking at integrating someone's environmental context and their personal context. So we're looking at why that behaviour is happening, given their environmental situation and given their personal situation. So that might be things like their individual and unique kind of difficulties and areas of strength. And so that's kind of the map that we try and come up with at the end of our assessment. Next slide, please. So once we've got our map and our formulation, we move on to our intervention. So in terms of PBS, the first thing we'd be doing is developing a PBS plan, which is a set of strategies to be used with the person to kind of support the person. We might also work along psychiatry if someone is prescribed medication, and we might be having conversations about when to start if they're not on, or when to reduce if they are on medication. So perhaps, you know, after we've done our PBS plan and that's been going well, behaviours are starting to reduce, we might think together about when it's time to reduce that medication. We do a lot of teaching and supporting carers and families. So that's probably the bulk of PBS, is trying to help the people around the person to implement the strategies and understand kind of why they're doing the behaviours. We might go along and do some modelling. So we might be going into people's homes and sort of showing how to use the strategies and reviewing the PBS plan. And we will also be taking that coordination role to kind of get the network together, to think about anything that might be missing from this person's life that we might need, for example, daytime opportunities or something like that. Next, thank you. So the PBS plan is a set of strategies to use to support the person in the best way possible, to increase the quality of life and to reduce the behaviours. So the majority of a PBS plan should be focused on proactive strategies. So that's things to do on a daily basis before the person has even engaged in any behaviour. So it's basically like a kind of, these are the things you need to do with this person every day to make sure they are happy and well and getting their needs met. Some of the plan is then focused on what we call secondary strategies. So that's things to do after we've seen early warning signs. So kind of signs the person might be becoming a bit upset or distressed. And they should be listed in the plan as well. So you should have a list of the early warning signs and what to do if you see them. And then only a small part of the plan is focused on reactive strategies. So that's what to do once the behaviour has occurred. So I think this can be quite confusing for carers sometimes because they want a lot of reactive strategies. What do we do when the person does this? But the more proactive things you do, and then the secondary things, you shouldn't need the reactive as much because you're preventing the behaviour from occurring in the first place. But we know that behaviour sometimes does occur, so we do need those reactive strategies there as well. So the reason I'm kind of going through this is because a PBS plan is only as good as the people who are implementing it. And I think PBS is talked about a lot as sort of this treatment for challenging behaviour. It's not a treatment, it's a framework we can use to try and find the best way of supporting somebody, but it does rely on people being there to actually kind of implement the strategies you're giving them. If people don't implement them, you're not going to see any change in the behaviour, basically. So that's one of the biggest challenges we face. Next slide, please, Tro. So this is just for you, just some resources on PBS for you to go and have a look at afterwards if it's something you're interested in. Next, please. So just to finish off, how and when to refer to psychology. So if there's behaviour that challenges present and it's a problem for someone, or the risks are high, or the other thing I'd say is if someone's having a lot of restrictive measures put in place, so lots of locked doors or physical interventions, then you might want to think about referring to psychology. If the person hasn't got a PBS plan, then come to us, or if they have one but it isn't helping, then you can kind of re-refer back to us. I've just put a note here that if they have one but the carers aren't using it or following it, there's not much point referring to psychology. I think the first thing to do is address this with the carers and thinking about how to help them to implement it. What's the barrier? And it may be that you come back to us and say, this is the barrier and this is what we need help with, and that's fine. But we can't kind of force people to implement strategies. And lastly, if the carers or individual actually want support, I think that's a key point. So I've just put some information there on who to refer to, and if you go on to the next slide, I think there I've put some, oh no, maybe not that. There is a slide anyway coming with some links to the different services depending on what borough you're in. So I just wanted to make a quick note of crisis and placement breakdown. So people with learning disabilities and autism should not be admitted to hospital for behaviours that challenge unless this is clinically recommended as appropriate. So we would call that a kind of inappropriate admission. So that's what we're kind of looking at under the Transforming Care agenda. If a client is in crisis or is at risk of admission because of their behaviour or placement breakdown is looking likely, you need to make an urgent referral to the intensive support team. So we've got intensive support teams in every borough in South East London apart from Lambeth at the moment, but for Lambeth you'd just refer into MHLD at the moment. And if medication is prescribed at the point of crisis to minimise the risk, it should always be reviewed regularly, and it should be considered to reduce as soon as it's safe to do so. Next. So that's your list of services. So there's some links in there you can click on if you need anything. And I think that's it. Go on to the next slide, please, Tro. Yes, lovely. Any burning questions for me? I'll stay around if there's anything that comes up over the session, but anything anyone wanted to ask right now?
Thank you, Jenny. That was really informative, and it was good to understand more about the behaviour patterns that could limit patient outcomes, and also how and when to refer, which I think will be very useful for people that are in a practice setting. If there aren't any burning questions for Jenny, we will move on. But if there is anything that anyone would like to ask, please do please do pop it in the chat, and we will, either Jenny or Tom will get back to you. So I will now pass it over to Liz and her team to talk us through CLDT and complex physical health. Liz, not sure, I think you've got colleagues here, so not sure if you want to do a quick introduction before. I'll pass it over to you now. Thank you.
Thank you. My name's Liz McGrath. I'm the lead nurse for the Greenwich Community Learning Disability team. I've got 3 other colleagues with me, so I'll let them shout out their names and where they're from, and then I'll carry on with the slides. Jolene, do you want to go first?
Yeah, sure. Good afternoon, everyone. My name is Jolene. I am one of the occupational therapists in the CLDT team.
We have Claire.
Hi everyone, I'm Claire. I'm one of the speech therapists in the Greenwich Community Learning Disability team, and I'm joined by Daniela, who's just joined us on placement.
And we have Kirsty.
Hi everyone, I'm Kirsty Bloom. I'm the Directorate Lead Physio for Learning Disabilities for the 3 boroughs, but based in Greenwich.
Thank you. So yes, first of all, it's just a quick introduction to the team and what each discipline does. And unfortunately, we haven't got all the disciplines with us. So I'm going to read through some of the slides that they have prepared. So we receive external and internal referrals. If you're going to make a referral, we need as much information on that referral form as you can possibly put. So the things that we're looking for is school and work history, whether people have done their GCSEs, what kind of work they've done, whether it's paid employment or voluntary employment. If they've managed to drive, because that's a really complex thing to be able to do. So that would aid us in a decision as to whether somebody's got a learning disability or not. And their reading or writing ability, whether they can read or write a paragraph or a couple of sentences, and what their money management might be like. If they've had any previous contact with a learning disability team or special schooling, and perhaps what their living situation might be. So I've just put up there the referral process for your reference. If people aren't known to our team, then they will need to have an eligibility assessment. So you can refer people to us and they will be put on our waiting list for an eligibility assessment. And we're a joint team, so we work alongside social care in our team. So our eligibility assessments are done by health and social workers within that team. Next slide, please. So first of all, we hit off with mental health and psychiatry. So that's mental health nursing and psychiatry. They're a specialised service and they work with preventing people going into hospital. So this is people that might go into a mental health crisis. They'll try and get in quick and support the network to support that person. They monitor people's mental health. They support with medication and the side effects, as well as carrying out physical health checks. So they run a clinic, a weekly clinic, where they'll see people and do basic obs and then write to the GP to let the GP know what those basic obs are. They promote positive mental health and wellbeing. So they run a walking group every Monday at Charlton Park, and that's a walk and talk group, so people can explore their problems. And like I said, the clinic, they offer therapeutic intervention and mental health assessments. Next slide, please. And they also work with a multidisciplinary team, like I said, social care. They support the dynamic support register. So this is a register of people that may go into hospital or hit crisis. It's a traffic light system, and if people hit red or amber, that's when the support increases. They do a care coordination role, so they ensure that care plans and risk assessments and crisis plans are in place. They do a clozapine monitoring clinic, and they work with service users and their family and support services to provide education, information and support regarding mental health. Thank you. Next slide. We have social care workers and assessment officers in the team, and they use the eligibility criteria laid down by the Care Act 2014 for all those that approach our service. And they're duty bound to offer an assessment, but not to provide support for all. They'll signpost people if they don't meet our criteria, and they've advised us to look at the Care Act for more information. Thank you. Next slide. So we have a psychology team, and they work with people with learning disabilities like we all do, and their networks, so family members, paid carers and other professionals. Some of the ways they work might be one-to-one therapy with people, bringing support networks together in network meetings, family therapy. Next slide, please. Systematic consultation with staff teams, training staff teams, so that might be teams in daycare settings or residential home settings, psychological assessments to see whether people have a learning disability or dementia, and we run a memory clinic that's held monthly for people that are diagnosed with dementia. And the psychology team at CLTD get involved with community projects and service user involvement. So we have a fun and fitness group that runs, well, several groups that run at the waterfront. We work alongside Greenwich Leisure Limited to run those. And we run a group, well, psychology run a group at the Tram Shed in Woolwich. Thank you. Next slide. So now it's over to Claire.
Thanks, Liz.
That's okay.
Yeah, so our role really falls into two main categories. The first being communication and the second being supporting people's eating and drinking skills. In terms of communication, the support really is very, very depending on who we are working with, but we have some of the reasons you might refer to as here. So we might support in terms of gaining and maintaining a person's attention, which is, really fundamental to all other aspects of communication. We do a lot of assessment and supporting around a person's level of understanding, quite often with other professionals as well. So if it is that you need to share important information with the service user, we can do some work around ensuring that that information is shared in the right way and at the right level for that person. A big bulk of our work is also around supporting a person's expressive communication, and Jenny touched on this as well. And a person's expressive communication really varies, again, depending on who we're working with. It could be that they have behaviors that they use to communicate their wants and needs. It might be that they use facial expressions. We have some people who use signs, so we might provide sign training to their carers or network. We have some people who might use symbols to communicate, be that on paper-based systems, or some people who use more high-tech iPads that they use to communicate. So we could support with applying for funding for those, but also supporting with updating the vocabulary, so make sure it's relevant to that person, and also supporting its use. We also, of course, support people who are more verbal communicators, both in terms of their language skills, but also for some people working on their speech. Another part of our role would be around kind of implementing care plans. So, if somebody has these recommendations for speech and language therapy, we want to make sure that the staff and family members are very confident and competent in using those. So again, it'll be going through those and modeling and working very closely with the person around the service user, or the people around the service user. And then also in terms of communication, we do a lot of work around a person's social skills and social networks. So while it's so important to have a way of communicating, it's just as important to have reasons to communicate and opportunities to do so. So things like Tram Shed and Fun and Fitness that Liz mentioned also, but also looking at the person's, home network and looking at the interactions there. If we could go on to the next slide, please. Yeah, and like I said, the second part of our role is around eating and drinking skills. So here we have all the kind of main signs and symptoms of dysphagia, which is the medical term. So things like coughing and choking, gurgly voice, a change in complexion, watery eyes. history of chest infections, weight loss, and dehydration. And really what we're doing in terms of eating and drinking is, I guess our ultimate goal is to support a person to eat and drink as safely as possible, as comfortably as possible, and also in as least a restrictive way as possible. I guess what's important there is we get a lot of referrals for people who've been discharged from hospital, who've been quite acutely unwell, whose diets might have been changed quite a lot when they're in hospital. And we really want to work with that person and their network to kind of bring them back up to their baseline, to how they were before they went into hospital, to make sure that they're enjoying all the foods that they normally would enjoy. That is a lot of kind of working with our colleagues as well. So we want to look at things like positioning, which links in with physio, or equipment, which links in with OT, and dietitians in terms of nutrition. Yeah, that is kind of a very brief overview of speech language therapy. But if you do have any questions, please do put them in the chat as well.
Thanks, Leah. Yeah, it's over to Jolene then.
Yes, yes, I believe I'm next. So yes, as occupational therapy within the ALD team, we look at the predominant impact of a person's learning disability upon their ability to participate in occupations. And we found that that has been something that people haven't quite been able to understand in terms of the kind of referrals that we get. You know, people often think if somebody's got a learning disability and they need OT needs, you know, they come straight to us. But there's a sort of niche area that we just look predominantly on how the learning disability is impacting on that person's ability to you know, to do the occupations. So for example, some of the things that we might look at, sort of skills teaching. As you know, people with learning disability, you know, they have difficulties with processing information, and so how their ability to learn is also impacted. So that's where OT will come in and look at you know, breaking down some of those tasks and those routines, so that they can be able to learn that occupation, or that sorry, one moment, my screen has just gone off on me, so I can't really see the slides. Bear with me. Okay, I'm back. So yeah, so that's one of the things that we'll look at. Also another point that we'll look at as well is sort of sensory processing difficulties. So again, we found that a lot of people with learning disabilities do have you know, issues with that because of their learning disability. They're not able to, you know, impact on how they interact with the environment and how they're able to again express, you know, those impacts, and how things like noise and you know, the temperature or sight and, you know, vestibular difficulties that some of our clients do have as well. So looking at, you know, what all those different sensory needs, doing assessments and interventions where possible, and with that again, with the goal of enabling the service user to be able to interact with their environment better, to be safe, and so that they can live an optimal life, to be able to engage in their activities. So again, sometimes we'll go into day centres where a lot of our service users do sort of, you know, spend their time, or sometimes in colleges, and then just looking at again, you know, what is the environment like, and how this environment is impacting on that service user's ability to participate, or, you know, in their performance. So again, looking at strategies that we can use to minimize certain stimuli in the environment, and making sure that it is pitched at the right level for that particular individual. So yeah, so we support as well access to mainstream health and social care. So as I mentioned, some of the things that we'll do, we do get a lot of referrals that are inappropriate, and just because of the sort of misunderstanding of what people sometimes think that, you know, our team does. So signposting to the, you know, right teams, and that we think their referral is pertaining to. We do a lot of consultation as well, and joint working, as Liz and my other colleagues have mentioned. You know, we are a joint service, joint with health and social care. So a lot of what we do is sort of, you know, MDT working. So as Claire also mentioned, recently. If some of our service users, for example, we're working on skills building and working on their ability to be independent with eating, for example, you know, we're looking at different maybe cutlery tools that we might be able to provide them if they're having issues with you know, how they hold their cutlery, or if their grip is impacted. And of course, work with speech and language therapists alongside that to make sure that, you know, that there's no sort of issues with maybe swallowing or chewing, or any impact in that sort, just to make sure that, again, we're looking at the service user sort of from a holistic point of view. So we also work with social care staff as well. So again, assessing the barriers to occupations, and then making sure that our service users have access to meaningful occupation. Again, as some of us might be aware of, that is something that is at a disadvantage to people in learning disabilities. Their access to mainstream services or just to activities sometimes is quite limited. So again, we work with social care staff to look at what activities or things are available in the borough, and looking at ways that we can maybe adapt it to be more LD friendly, and how our service users can access some of these services. We've just recently done a pilot with our nursing team, looking at sort of cooking, enabling some of our service users to cook, and improving their health and well-being, and introducing sort of healthier meals as well. So those are some of the things that we'll be looking at, and we're looking to do sort of more of that kind of project work in the future. But yeah, so it's just about looking at what is available to our service users, because sometimes they might not be aware of it, and just again signposting them to some of these services, so that they can engage in their occupations. And of course, yeah, identifying strategies to increase engagement, participation, and performance. So a lot of what we do as well is sort of routine building. So again, looking at the service users' routine. Some of them might have very sparse routine and not have much going on in their day, which of course can impact on various other things that might cause, you know, create behaviors that challenge. And so it's here again, we'll come into that, look at sort of the interest, what it is that those that individual likes, to engage in, looking at again if there's any going to be sensory impact to that. So looking at the individual again from a holistic point of view, and then creating a schedule. Again, sometimes we liaise with speech and language with this regarding communication. So using sort of now and next cards and symbols, or having sort of pictorial, you know, breakdown of routines or of activities, so that the service user can be more empowered to sort of choose through looking at pictures of what activity they want to engage in that day. So again, we try to, you know, make the activity quite varied, so looking at leisure activities as well as sort of productive activities where a service user can learn some skills or maintain some of their skills that they have as well. So yeah, so that's sort of in a nutshell what we do in the ALDOT. And yeah, if there are any questions or need for clarity, then again, you can put it in the chat and I'll be happy to answer them. Thank you.
Thanks, Jolene. I think it's over to Kirsty now.
Hi, Liz. I just wanted to remind, in the interest of time, we might have to try and wrap your part up if that's possible.
Okay, if we could just have Kirsty on quickly then, and then I'll just leave the nursing bit.
Thank you.
Okay, I'll try and do this as quickly as possible.
The next slide.
Main role for us, the biggest role for us is around facilitating 24-hour postural management for those with complex physical disability. So I think the main point I'll try and get across this all in, most of what we do is there in the text for you to read later, but I would get across the point that we cannot, as a specialist service, meet all of the physiotherapy needs of everybody with a learning disability. And if somebody has a need for an MSK input, for falls input, for a COPD perspective, or input around rehabilitation from stroke or other significant orthopedic issue, they should be able to access those specific services that already exist outside of the CLDT. A lot of our role sometimes is in enabling those services to make reasonable adjustments to meet the needs of people with learning disabilities, and often to pick up where they leave off when they have only a time limited intervention. So we'll sometimes pick up someone's rehab when it's going at a much slower stream than the service will allow. We do provide some specialist input around things like hydrotherapy. We're launching a new respiratory assessment service for those with learning disabilities, because we know that respiratory cause is the leading cause of death for people with learning disabilities. So that's a joint enterprise between physio, SALT and LD nursing, where we're trying to do a very kind of in-depth review of people who we perceive to be at high risk. And then make referrals on to other specialist services for intervention where necessary. A lot of the work we do is with service users, carers, support teams. So we will do a lot of work around teaching them to use interventions to help maintain people's posture, maintain their tissue viability, keep people mobile, keep people's chests clear. Obviously we cannot deliver those services on a day-to-day basis, so a lot of our intervention is done via carers. I think if we skip on to the next slide, I'll just check if there's anything there. We do a lot of liaison work, so we don't need people to be referred to us in order to access things like wheelchair services or spasticity clinics. If we're already working with people, we will obviously try and facilitate those referrals, but people don't need to come via us. We do get a lot of referrals asking us to make onward referrals, which is just wasting everybody's time really, because but we will get involved in wheelchair clinics, and we will attend spasticity clinics and things with people where necessary to support, and we'll obviously do quite intensive work with people if they're having things like Botox, to try and facilitate the best results from that intervention. Lots of, as everyone else has said, lots of MDT work, and lots of work around muscle tone, muscle length, range of movement, positioning and posture, factoring in all those communication issues and other complexity issues around behaviours that challenge, etc. So that's sort of the summary, is that, yeah, I did that as quick as I could.
Thanks, Kirsty. Yeah, apologies to the next speaker for running over time. I didn't realise we did so much.
Thank you, Liz and the team. That's been really, really informative, and great to find out a bit more about some of the projects and services that are available. So in the interest of time, if there are any questions, if you want to just pop it in the chat, and we will move over to Elizabeth, who will give us an overview of the commissioning point of view. And we aim to finish sort of a couple of minutes before 1. So we've got a quite short questionnaire for the team as well. So over to you, Elizabeth.
Hello, thank you for inviting me, and I will try and be quite quickly. So in Bexley, this is on behalf of Bexley, we are an integrated team. I'm the head of integrated commissioning there, and so I therefore work for the South East London ICS as well as the London Borough of Bexley. Could you move a slide, please? Thank you. So we are that team, both health and social care, particularly for LDAP. One of our things that we like to tell everybody, we don't have any clients that are placed with specialised commissioning, SLP. We have nobody in the 5-year cohort and nobody placed outside our area. And in fact, we haven't had a person with a learning disability as an inpatient for over a year now. Could you move the slide, please? So the way that we actually manage that from both sort of a health and social care, but I'm talking to you on a with a social care lens today. So we case manage those who are at risk of admission or are an inpatient. And we do that firstly by chairing a CTR. So that would either be before, if we think, you know, that it's a crisis and we've got a chance to put measures in place to prevent an admission, or we will always do a care and treatment review once somebody has been admitted to hospital. So the care, and I put the E in there because that stands for care and education treatment review for those who are children. It's chaired by the responsible commissioner. We have a panel that sits on that. So we have an independent clinical expert, an independent expert by experience, usually somebody who has a child or a relative with a learning disability, or in some cases has autism themselves. We have representatives come along to that meeting from social care, the psychiatric mental health team, the named nurse, the OT, SALT, psychology, and others may be invited. If the FIND team, which is a forensic team, are involved, they will be invited. And if the person is in the sort of 18 to 25 year age group, we would invite the select who are key working for that age group. We can invite pharmacy and a challenging behaviour team as needed. So I've just, in the interest of time, I've just put on the other side of the screen what we're actually looking at in a care and treatment review for your information. So rather than go through them all, I think they're all quite self-evident of the questions we're asking of all the professionals that attend. Of course, the person themselves will be invited, and in fact the care and treatment review won't actually take place unless they give consent, or if don't have the capacity to do so, that best interest decision is taken. Their relatives are invited, but only again if the person gives consent. So should we go on to the next slide? Are you happy with that? Just to read the key lines of inquiry. So the second way we support, and showing the integration, I suppose, following on from the previous speakers, we have 4 to 6 week reviews of the dynamic risk registers. So that is with the CLDT team in Bexley. We meet with them every 6 weeks. They are wonderful. They turn up in all forms, from the psychiatrist to the nurse to the key worker for somebody, SALT and OT as required. And we also have a dynamic risk register for autism, and we hold that to review the cases with our intensive autism team. So the dynamic support register is for people who are inpatients, but the most important work we try and do is those that we're RAG rating, the traffic light system, who are at risk of admission. So all those ratings are gathered by the health professionals as amber. We will discuss at regular meetings. We will bring in a multidisciplinary support as required. We try very hard to prevent the admission or the breakdown of the care and living arrangements, which is often a precursor to somebody being admitted. Could you move on, please? Okay. So our approach, and I am speaking on behalf of Bexley, so we've got a dedicated resource to case managing patients. So this person will attend all the care and treatment reviews, and will sort of start to note the social care input that's required. That person then contacts the social workers, housing, preventative services, social care providers right from the outset. So we don't leave it until somebody is ready for discharge. We're starting to look at somebody and what their likely destination is and what support they're likely to need right from the first meeting with them. And I just wanted to give you a brief case study of, I think, why we've developed this methodology of actually helping people out of hospital. So we had a learning disabled client in 2018 who had been in Atlas House for 18 months with no provider willing to accept them. From the CTR, the care and treatment review, we determined that it was the professional language being used in reports, and the providers felt the person was so high risk that we were moving from more specialised provider to more specialised provider, looking further and further afield. But by actually sitting down with all the professionals there, this young man was said to be touching females inappropriately. What he was actually doing is he missed his mother so much that when he saw an older female, he wanted a hug. There was no sexualized behavior there whatsoever. He was you know, we're looking at positive behaviour. All he wanted was his mom. So obviously, because from a social care point of view, we've attended that care and treatment review. We have a good scope of providers we can talk to and actually explain to them what's going on. So although technically on a hospital ward you do have to use professional language, we were able to intervene, and I'm really pleased to say he'd been there for 18 months. We were able to discharge him in 4 weeks, and the last I heard he was playing for a football team every week and loving it. So just to show you that sort of the input of social care into that. Could I move on to the last one? So what we offer, so an individual based support, we will coordinate the circle of support available, often being the one who hosts the meetings. We will liaise with the social care services, support groups, and this does include pharmacy. And Tom, who's arranged this today, has been so helpful in looking at medication for us for people where there's been rapid changes, there's been side effects, and some people have entered hospital as an admission with such a list of medication. It sort of takes several pages, and we so value the second opinion to look at that. So we will do an active review of clients at risk of admission, trying to get the support in place. We also go to the social care funding panels to actually put our own case. So we don't leave this simply to a social worker or a care coordinator for mental health. We go as well. And to date, we've never had a delay or a refusal to fund. We also, which I think is quite important, is we ring the hospitals every single week. Somebody's in there. So we're following the progress and we're adjusting it. The support that's required, bringing in all you professionals as needed. We don't leave it from CTR to CTR. We are there every week finding out what's going on, and we carry out an 8-week commissioner oversight visit. Thank you.
Thank you very much, Liz, and thank you everybody for attending the webinar. Thank you for Jenny, just to bring up the idea of PBS, and the key take-home message is clearly when you engage with a patient with learning disability and or autism. So if the behavior has been of an issue or a concern, then there is always a reason behind the behavior, and whether we can actually identify the reason and find out after. So just to emphasize that the ABC chart and sometimes the PRN protocol are used in primary care to review those medication and whether they are effective or not. And then thank you, Liz, and the community LD team in Oxley for sharing what the referral criteria is or what your roles are. So I'm hoping that everybody attended the meeting or the webinar would now have a clearer sort of insight on where to refer to. And finally, thanks, Elizabeth, on mentioning about your case study, the behavior of one of your client or service user that may lead or may have led to inappropriate or unnecessary prescribing as well, when there is a right team that could actually offer a right support. So just to emphasize that if you do have any sort of feedback whatsoever, we do have the QR code on the slide that is on the left side of the slide, where you can easily use your phone to scan it and then give us some comment on what went well, what didn't really go well, or what you would expect to see next time, or what sort of topics that you would like us to talk about as well. So there is also a very convenient chart that we just adopted from Jenny's slide. Just to emphasize again, for LSL Borough, you have the links for camps, and for adults you have the MHLD links as well, for the SLAM only. So if that is for community LD team, then if you are in the LSL Borough, you have to liaise with the Guys and St. Thomas team, which is also on one of the link on there. But if you are BBG Borough, we do have the Oxley team to support you. So again, with the children on the camps, and then the community LD team and the MHLD team are also based in Oxley if you're in the BBG borough. And obviously, if there is any sort of issues around LDA, or if you would like more information, advice or recommendations, please do email us on LDA prescribing team at South East London and ICS.NHS as well. So I hopefully today it was useful for you, and please let us know whether that was anything else that you would like us to talk about next time. But there was one question that I saw earlier on for Jenny specifically around PBS. So we are wondering what whether the PBS is actually, how often is it actually reviewed in the community when you have got this formulation for the service user, and whether pharmacy or pharmacist or clinician in the primary care would have that information so that we can review it in primary care as well.
Yeah, so we don't, once we've closed somebody, we don't open them to review it, but we'd expect that their sort of care team, kind of their staff team, if they've got a staff team, would review it every sort of 12 months or so, or if there's a change. I wouldn't be expecting kind of pharmacists or GPs or primary care staff to be reviewing the PBS plan, but I would hope that maybe after today you feel a little bit more confident to ask if there is a PBS plan and if staff have access to it and are following it, or if the family have access to it and are using it. Because normally when we ask that question, we often get a lot of blank faces. So it's just about then contacting the psychologist and saying, could I have a copy, and send it over to the staff, because maybe the staff have changed or it's got lost or whatever. So hopefully that's a good question that everyone can ask is, do you have a PBS plan? If so, where is it? Have you got access to it? Are you using it? And then if not, and if it does need reviewing, do re-refer back to psychology and we can review it.
Thank you, Jenny. And any other questions that anybody might want to bring up? And in that case, thank you everybody for attending. Oh, Rena?
Oh, sorry. Just very, very quickly, on the back of the same question for Jenny, thank you to all the presenters. It's been absolutely very, very educational. Jenny, there was a little bit of a question there with the mixed diagnosis with LD or autism, but also mental health. That becomes the deprescribing or stepping down a bit more challenging because different specialties are managing. But I would assume it'll be in the care plans. And this is where the medicines reconciliation bit in primary care becomes a much more useful or important tool to manage.
Yeah, exactly. And if you're ever kind of thinking, oh, actually this person could do with some psychological therapy around psychosis, for example, that's something that psychology can offer. So say, for example, you're kind of worried about the psychotic symptoms coming back if you were to deprescribe the antipsychotic. That's a good reason to sort of refer into psychology or psychiatry if you're feeling I'm not quite sure where to go with the deprescribing as well. So, there's a specialist team there for people with learning disabilities. So always come and ask our advice if you need anything. You don't have to make a formal referral. Just give us a call and we can have a chat over the phone even.
So just to make it clear for, I don't know if there are any primary care PCN clinical members here, for those who have acute prescribing from your service, they will remain under your care because it's an acute presentation and acute management of the problem. The STOMP element about deprescribing, which we are trying to ascertain, is for those patients who are stable and are actually asymptomatic and have been left on this psychotropic drugs without any additional ongoing benefit. These are the ones that we want to tackle. And again, with the help from your team as well. Am I correct in the distinction of the two?
Yeah, I suppose STOMP is for anyone. They could be in a kind of more acute presentation, and we still might think about deprescribing for other reasons, for example, side effects, or perhaps we think it's not actually a helpful medication for them. But yeah, I think there are two distinct cohorts there. There's the people who are open to the team, who are having active work, and then there's people who we've closed because everything was stable. And so primary care are managing those people. But yes, do come to us for advice, even if you don't want to make a referral. You've got a wealth of expertise across the teams in each borough.
Thank you.
Welcome.
Thank you, and thank you for everybody for attending, and thank you to our special speakers.
Thanks,
And
Tom.
I just want to remind that we have the next webinar on the 8th of March. So I hope everyone will be attending and look forward to there then. Thank you everyone it's been great.
Thank you. Bye.
Bye.